All right then, good afternoon and welcome to this UK FPO Foundation Programme curriculum update. Some of you, or those of you who don't know me, I'm Tony Choules. I'm one of the advisors to the UK FPO and I'm chair of the Academy Foundation Programme Committee. And I've got with me today Fiona Cameron, who's the Foundation School Director for Scotland and Vice Chair of the AFPC. I want to start off with a very brief review of what we've done so far, but one of the main points of this afternoon really is to get some feedback on the curriculum and think about anything that we might need to do to update it and change it, having lived through 1 year of it. So essentially, the questions that I'd like you to sort of think about as I go through are, has the curriculum worked for you? Have there been any challenges or difficulties? Is there anything we should particularly change that you really feel just wasn't right? And one of the things that's really, really important is the curriculum fair? And this is something that's becoming more and more sort of mainstream, I suppose, in medical education, trying to ensure equity of training for the vastly different groups of people that we have coming through our training programs. So just as a brief reminder to sort of think about what's been happening over the year, you'll all be familiar with this. Our foundation program is to receive people into medicine or into the practice of medicine and give them a grounding for the start of their professional career. The GMC requires us to review our curriculum on a regular basis, and this was the first update since 2016, so we'd had the old one for 5 years, and we went through a process of seeking feedback, developing ideas, going back to people, getting the feedback on them, and an iterative process of trying to develop the curriculum in what we hoped was right for this time, bearing in mind that those of us practicing medicine now, or certainly people at my stage in career, medicine has changed a huge amount since we qualified, and almost certainly will change during the working lifetime of the current foundation doctors. You'll recall that this new curriculum has 3 higher level outcomes. One is to be an accountable, capable and compassionate clinician. The second is to become a valuable member of the healthcare workforce. And the third is the professional one, responsible for their own practice, for developing their own portfolio, as we all have to do as we go through our careers, whether we have a fairly straightforward career or a portfolio type career. It's important that we keep a record of what we do, as this is part of our ongoing training and revalidation. You remember, hopefully, that we broke those down into smaller parts to try and sort of fit in, certainly on the clinical side, with the process, the patient journey. We also had the section on the healthcare worker, where we look particularly at values and working in the team, and then the concept of sort of understanding medicine in the 21st century. The FPCs, 3 FPCs were broken down, or were not broken down, we gave examples within the curriculum of behaviours that we expected foundation doctors to demonstrate while they were working in the workplace, on the wards, in the GP practices, and the other areas that they were practicing. And we wanted the whole process to be a sort of hands-on learning, where the best thing that we could do to I suppose give our doctors experience and to assess them in that process was to look at them and see how they behaved in the workplace. We set some standards where F1 was essentially getting used to being in the workplace and being at a state where you could entrust them to work safely in a relatively supervised environment. And you remember that the GMC requires us to include the prescribing safety assessment as part of the requirements for F1 completion. F2 was designed to build on F1 so that we had a group of doctors who were capable of beginning to work, certainly in the generalist areas, in a slightly less supervised way, being given areas to look at, groups of patients to look after, checking in with seniors as needed, able to spot difficulties and bring them up as they needed to, but also to broaden their skills into all the other things we need to be able to do within medicine, so teaching, audit, quality improvement and this sort of stuff, and also to think about their future and what they want to do going forward as a career. As I said, it was all about experiential learning, the idea that they go in knowing certain things that we know about them, and gradually develop these through a process of reflection and feedback to develop their skills. Alongside the ward-based work, we talked about, or we provide training for our doctors, and we currently require them to demonstrate 60 hours of learning outside the standard ward environment or the standard workplace environment. And 30 hours of this we define as core learning, and 30 hours is things that they choose to do to develop themselves. And you may remember that at the beginning of this year, we specified core learning topics that we would expect all foundation schools, all places training foundation doctors, we would expect them to include these as core topics. And my vision is that when some of this becomes mainstream, we remove some of these core topics and we put in new ones that are more current and more relevant. And you'll recall that there was no specific requirement to complete an ILS or an ALS course as part of that core learning, although the competencies for acute care are very clearly in there to the same standard in the FPC2. We wanted to make it an experiential process, and what we wanted was doctors or the foundation doctors to form or complete a portfolio where they could demonstrate the skills that they'd learned and demonstrate that they were ready to move on to the next level of training. And we used this hierarchy of evidence where actually what we really want to see is them doing stuff in the workplace. But if we can't see them doing that, then they could demonstrate it perhaps in simulation or in other areas. And this has got to be supported by knowing certain things. We're not going to see every patient of every kind, but if they can manage certain sick patients and they know the background of other patients or the background of treating other patients, then they can apply those. They can apply those should they encounter the different patients as they go forward. The sorts of evidence they can provide is quite wide, particularly the supervised learning events, which we did. Which has been in the curriculum for some time. And one thing we did this year was to put in no particular number of SLEs. We just wanted foundation doctors to do what they felt was enough to show their abilities. And one of the interesting things that's come back, and it may just be a custom and practice thing, is that the average number of SLEs is roughly the same this year in portfolios as it was last year when there was a specific number mandated. We had other things in the portfolio, so records of their training, reflection, some multi-source feedback. And one of the things we put in specifically this year was a requirement, so as well as getting the multi-source feedback, a requirement to have feedback from a placement supervision group in at least one of their placements. And we stated in the curriculum that it was good practice to do it in all 3 placements, but we accept that sometimes this is more difficult. So at the moment, we're just having one requirement, and this I think is quite important. It makes the trainee, or it makes sure the trainee gets a fair hearing from a variety of professionals, and I think to some degree it protects the supervisor, so that if they are giving if they are having to give a poor outcome to a trainee, or they're having to feed back difficult things to a trainee, they've got support from other members of the healthcare team. And whether we like it or not, pragmatically, it's usually the ones who don't do very well that will complain. I think they're unlikely to complain if they get good feedback from their supervisors. We did include this year the summary narrative, you'll remember, and this did cause a few problems. I had a number of questions through the website about this, but the principle was it was to give the foundation doctor an opportunity to talk about why they'd included certain things in their portfolio of evidence, to demonstrate that they'd achieved certain parts of the curriculum, and we felt it was a very important form of reflection, really, to look back and think about the things they learned and done. Hopefully we've got the message across that as well as physical healthcare needs, foundation doctors need to learn about mental health issues, and we require evidence not only of being able to care for patients' physical health needs, but also their mental health needs, and understand the social context of health as well. And with the generalism project that's coming up in England, there's certainly, you know, I think this seems to be something that's becoming more and more mainstream, more and more important in medical practice. And then taking from the old curriculum, or the previous curriculum rather, demonstrating their skills both in the acute situation, in the management of chronic diseases and chronic problems, and again fitting this into the background of community care and community health. So hopefully giving foundation doctors a very rounded foundation for their career. Many of you will have seen this recently. You've probably looked at it very carefully when you've been doing your ARCPs, and this is the list of the requirements at the end of the year to pass the ARCP. One of the things that we did try to emphasize very sort of firmly in the curriculum that comes out a little bit from the foundation program review was the lack of experience of foundation doctors and the need for close support, and particularly the need for an understanding of doctors from some backgrounds who may need extra support, and I suppose a willingness from supervisors to perhaps explain things that are very obvious to some groups, and I'm talking particularly here about UK graduates versus international medical graduates, but also thinking about the backgrounds of our trainee doctors to ensure that we provide them with good support in their placements. And just to emphasize, this is all about producing a broadly based or a broadly grounded doctor who can then choose to move on and specialise as he or she chooses. Hopefully you've all visited the curriculum page of the UK FPO website, which has got the details on. There's a lot of useful documents on there for those who haven't, things to explain how you do certain parts of the training programme and the curriculum. Yeah, I think that's probably what I wanted to say around the curriculum. So this final slide really just sort of summarises the changes we've made, and hopefully will remind you of some of the questions I asked at the beginning about the process. So what I'd like to do now really is hand over to Fiona and to everybody listening to give some feedback on what's happened, ask any questions that you require some clarification on, and generally perhaps open up a discussion of how this first year's been and how we take things forward to next year.
Thank you, Tony. So thank you very much for that. That summary update of where we are. I'm very happy to take some questions. I've been seeing there's been quite a few questions coming through in the question and answer.
First question, Fiona, is not having minimum numbers of SLEs has made it difficult for trainees to understand how many would be sufficient to populate the curriculum. Also, it's difficult for supervisors to assess adequate progress.
Okay, that's an interesting question, and it is a question that has come up several times. Obviously, we were required by the GMC to take away the number of SLEs that were actually required, and that's for all curricula, not just the foundation curricula. But understandably, it has caused some angst and some confusion within foundation doctors and their supervisors. We have provided some kind of guidance in that they cannot link their SLEs too many times, so they are forced to do a few SLEs. It's very much up to the supervisor to look at their SLEs, to look at the content of the SLEs, and to see whether they have actually met the requirements of the curriculum. So one of the things that we have done is ask the trainees to provide a summary narrative. And in that summary narrative, we've asked the trainees to say why they feel they have met the higher level outcomes. So it may well, I mean, theoretically, you could have 2 or 3 SLEs which would actually meet all the curriculum requirements. But we've said to the trainees that ideally they probably need to be doing similar to what they were doing before, which was around the sort of 15 mark. But we can't say a specific number, because if we say a specific number, that will become the number. So again, it's about reading the curriculum, reading the SLEs, and seeing if they've met the requirements. Okay, are there a minimal number of reflections per placement needed? Again, we haven't put a specific number of reflections in, but you will need to put some reflections within the portfolio. So ideally you want, a few per HLO, and of course the summary narrative is a reflection, is a piece of reflection, and we need a minimum, we need 1 summary narrative per HLO. There's been a few questions coming in about the PSG and the tab and what the difference is, and there is quite a clear difference between the PSG and the tab. The tab asks for questions about the trainees' communication, about their accessibility, about their communication with the doctor, with the team, and also with the patients. Whereas the PSG actually asks questions about the doctor's performance, about their clinical capabilities, whether they're competent clinically, whether they're demonstrating that they can prescribe, and that they can make good clinical decisions. And actually we heard very strongly from the foundation doctors at the beginning that they wanted, they felt that the tab told them whether they were a nice doctor and whether they were nice to their team members, whereas the PSG told them, gave them information about whether they were a good and competent doctor, and gave them areas for professional development within their clinical care and clinical competence. So I think probably what's been happening in the past is that people have been using the tab for this facility, whereas now we have a different tool to tell us whether they're good doctors or not, whether they're clinically competent, with good clinical decision making and prescribing, and that is in addition to whether they're accessible, good team members. So it's now having 2 tools, use it appropriately rather than everyone just piling it into one tool, which was the tab. There's a question here about study leave and annual leave. I think I'm going to not going to include this because it's not really curriculum, that is related to terms and conditions, and that's a 4-nation, it's different across all 4 nations about study leave and annual leave, so I'm going to give that one a miss. Another question here about the PSG, who can constitute the PSG? It says in the curriculum that it's senior clinicians. So within the PSG, it can be senior members of the medical team and senior members of the nursing team and allied healthcare professionals. Whereas the tab is very much communication based, so we maybe have the ward clerk, we can have other foundation doctors, other members of the team. But if you're giving advice on clinical care, then we're looking for senior members of the ward or the general practice community. Next question about single place where we can find the requirements. I would always say look at the UKFPO website. Your foundation school director is always provided with up-to-date curricular requirements, and they haven't changed over this year. It may just seem that they're changing, but hopefully they won't change again this year, because we have our curriculum embedded. But certainly the UKFPO is the place to access curricular requirements. Another question here about the summary narrative. Does there have to be a summative assessment for each FPC for ARCP requirement? No. The answer to that is there has to be a summary narrative for each higher level learning outcome. So that's a summary narrative to evidence the doctor as a competent, capable and compassionate clinician. That's HLO1, HLO2 a team member, and 3 as a lifelong learner and widening of wider aspects of medicine. So 3 summary narratives for the year, 1 for each HLO, but not for each summative, not for each FPC foundation professional capability. There's another question here about SLEs making it difficult for trainees to understand. I think this will embed as time progresses. It has been a massive sea change, and this is not just applying to foundation. Having no minimum numbers has made it slightly. It's a new situation for everyone to navigate. And obviously makes people feel a little bit uncertain. Have I properly assessed this trainee? But I think as time goes on, it will make people will begin to understand what a properly evidenced curriculum looks like. My advice to trainees would say that if you provide plenty of evidence, then you will not be short. Whereas if you try and get past with very little, then it is likely that you may not have met the curriculum requirements. And also with reducing the burden of assessment, then hopefully your supervisors won't have to spend hours and hours reading the content, but you'll be producing high quality evidence within your portfolio. There's a question here about why is there not a shadowing period for standalone F2 similar to F1? Again, that is contractual, and I think I'll just leave this one alone here in this format. There's a question here about knowing what evidence to link to HLO2 and 3. So for HLO2, you're looking for evidence of team working. So you want to perhaps link your PSG, link your TAB, link evidence of communication, and a link to teaching that you have done. So not teaching that you've attended, but teaching that you have delivered, and any quality improvement activity or audit. Dare I mention the word audit? But certainly that's where you'd be linking your to HLO2. HLO3, you want to evidence that you have taken part in your portfolio. So just by developing your portfolio and having ongoing activity in your portfolio will help you evidence that. If you have attended taster sessions, if you've done any modules on careers, that's where you'd want to link to HLO3. So there's actually clear guidance on the UKFPO website on how to build your portfolio. There's a short video to watch about building your portfolio, and that gives you further information on what you might want to build and how you might want to build HLO2 and HLO3 evidence. Another question about the PSGs. Interested to know how people select their PSGs. I find it very difficult with rotas. The doctors can be all over the place in terms of which registrars, consultants they're working with through the placement. In some ways, it might be easier to select the PSG members later on in the placement. Is this acceptable? I think yes. I think one of the reasons we've put it in early in the CS induction meeting is to remind everyone that they need to create a PSG. and doesn't get forgotten about halfway through. However, I do appreciate that certainly at the moment where units are moving around and doctors are moving around, then it can be quite challenging. I think it depends on each supervisor and how they find their departments and their placements are working. So I appreciate it is difficult, and hopefully as things move forward, then we might be in a more stable position where our wards are less subject to moving around. Next question here is there a minimum number of responses for the PSG? Yeah, and is the summary released after the supervisor report has been written? Is there a way of it to be displayed within the supervisor report? So I think the PSG, certainly in Scotland, sits within a certain tab, the different tab from Horace, and I think within Horace, I think it again appears in a PSG tab. And in terms of the number of responses, we in the past we asked for 3 responses. However, this year we have asked only for 1 PSG response. Now, I understand that whilst you might have only 1 person writing a response, then the validity is questionable. I think very much if the supervisor feels that they need more, then it's very much up to the supervisor to ask for more. Going forward, I think we will be asking for increased numbers of PSG, but remember this was relatively new. This has been a difficult time with COVID. Everyone is tired, and what we didn't want to do was to overburden people until it is well and truly embedded in the assessment process. I've got another question here about the PSG. We've lots of variability in the number of responses, and I think that again very much before. My advice would be the more responses, the greater the validity, and it also gives the clinical supervisors some additional cover and protection in terms of when they're writing their supervisor report. The PSG is also very helpful for the trainees, so the more feedback that they get, you do more of this and do less of that, is actually very positive. And remember, when these people are going to apply for specialty training jobs in general practice, if they've got really positive feedback where they've done really well, it's really helpful for them to have that in their portfolio. I think going forward we will have increased numbers, but at the moment we are sticking to where we are. Next question is about trainees who had lots of SLE and reflections, and others who only had modules. I know both are good, but it didn't look fair on paper. Is there anything I need to do? Okay, so what we say, if you think back to the slide that Tony showed about the hierarchy of learning and the hierarchy of evidence, SLEs are right at the top. These are evidence of experiential learning, and actually modules and teaching sessions sit very much at the bottom of the pyramid. If you are to assess somebody on their competence, assessing them experientially in the workplace is the highest level of evidence. So for SLEs, for FPCs 1 to 5, so HLO1, I wouldn't be accepting modules as the only piece of evidence, and these SLEs, these FPCs absolutely need SLEs rather than modules. So I would go back and say that's not enough if you need more. Next question, it's going to take me a minute to read it. It's difficult for the ES to deal if the issues raised by doctors in the department are not sorted out there and then, especially by the clinical supervisor prior to the end of the posting. Got a difficult situation recently. Is there any guidance towards this? I'm not entirely sure. I think the question is relating to things that are brought up during the post and not necessarily reported to the clinical supervisor. I think you probably just need to deal with your foundation TPD in that situation. I don't think the electronic system will deal with it. I think that is something that you very much need to speak to your foundation TPD to get support and advice from, and I don't think the portfolio can replicate that information. Is another question here about the early sign-off for FYs in late May, early June, and that's some trainees being signed off before issues are noted. Okay, so this is a difficult situation where in the third post we need our trainees signed off. We are very much governed by the GMC on this one, and we have to have everybody's evidence submitted by the very first week in July for full GMC registration and the completion certificates for F2s. If we work back, we have to give them time for outcome 5s, we have to give them time to actually have their evidence reviewed by their education supervisor and their foundation programme director. So we are pulled back to that end of time, that early date. If there is any suggestion that the trainees need longer, then supervisors may well be allowed a little bit longer to assess individual trainees. Equally well, if things appear after sign off, then that involves a discussion with the foundation training programme director and probably the foundation school director for a bespoke arrangement to happen. If that is something that is a problem, then for the person who's asked this question, then I suggest they get in touch with their foundation TPD or their foundation school director to deal with that particular situation. A question here about duplication under different headings when doing the end of placement assessments. We'll have a look at that. That's a good comment, and we will have a look at that at our foundation curriculum development group, and we'll make sure that it's not duplication. That's certainly not something that I picked up on, and we will take that point back. Thank you for that. Next question about somebody who got PSG feedback that was unsatisfactory and went on to the next post, but it raised some serious issues. Again, that needs to be taken up with your foundation training programme director. Struggle to get this clinical supervisor to understand the change. Encourage your local hospital, your local school to do training sessions and maybe signpost them to this webinar. But rather than pick out any individual people, perhaps organise local CS/ES training events. Question about the summary narrative. The summary narrative has caused real confusion. A lot of doctors didn't seem to know what it was for and slow to get to grips with it. I think that's understandable given the fact it's new. And again, there is some guidance on the UKFPO website about how to build a portfolio, about how to create a summary narrative, and I would signpost people there. I'm hopeful that as the year goes on, and this year, then it will not be new, and people will become more comfortable with it. Everything that is new always creates challenges and gives people, it takes people time to work out what to do with things. Another question about what's meant by senior members in the PSG. Again, that's very much who the clinical supervisor thinks is a senior member. So I think consultants, definitely. I would say the senior trainees. And
GPs, Fiona.
And GPs, yes, sorry, and GPs. I probably would not include a core trainee. We include SAS doctors on that, who are educational and clinical supervisors. I think if a clinical supervisor is asking a core trainee to comment, then that clinical supervisor has to be very confident that that core trainee is of a suitable seniority to make a valued judgment on that foundation doctor. I think the bigger the gap between the foundation doctor and the PSG contributor, the better. Next question about the summary narrative. So it says, the end of each placement, do they do one summary narrative per HLO or one summary narrative to cover all three? So at the end of each post, ideally, they should be looking at developing their summary narrative for each HLO. At the end of the year, they want one summary narrative per HLO, not 3 per HLO, but it can be started towards the end of post 1 and developed at the end of post 2, and then by the end of post 3 they have something that actually is a full summary narrative. So we want one for each HLO developed through the year. Gosh, these questions just keep coming in. We have one lift F1 doctor in public health for 1.5 days a week. Can we focus on the F2 standards? I would say the trainee has to evidence the F1 standards to meet the curriculum requirements, and anything else that that foundation doctor has done in public health then can be added in as additional achievements, but they will not be measured against the F2 standards. They'll be it's a bonus rather than a requirement. Again, the PSG, mandating one PSG was difficult as the responsibility of the CS to undertake it and not the trainee. And the trainees got stressed when the CS didn't do them. Again, I think this is about additional support and learning for our clinical supervisors to keep the to embed the PSG, and I think it'll improve as we go forward. And a question here, how do you expect that a foundation trainee will be competent? Supervisors who supervise foundation doctors are very competent at understanding what a competent foundation trainee looks like. The nursing staff, the general practice, the allied healthcare professionals are all very aware of what a competent foundation doctor looks like. And what a foundation doctor who requires additional training and support looks like. And we have found that over the years, this feedback into the portfolio is very robust in how it assesses foundation competent doctors. Another question about the CS and the PSG, why is it not the FY? We know that for the tab, the foundation doctor chooses their friends to complete the tab, whereas the clinical supervisor is able to select people who they feel will give valid clinical feedback to the foundation doctor. And so it is different, but the FY does not necessarily know who's going to give them valid and clinical feedback. Next question again about the ES requesting a PSG report. It says also, do we need one single PSG report from the PSG lead, or there can be one more report? No, the whole value of the PSG is that multiple respondents feed into it to give meaningful feedback for the trainee. Another question here about the summary narrative less meaningful. I'm hopeful that as time goes on, the summary narrative will be more meaningful. If you equate the summary narrative to what consultants and GPs have to do when we put in our evidence for appraisal annually, we have to write in our appraisal documents why we feel we have met the requirements of a GMC registered doctor. And essentially what we are trying to do with the summary narrative is to train the foundation doctors to learn this skill from an early stage. When they enter specialty and general practice training, this will be developed, and I know that many of the specialties, general practice, paediatrics, mental health, for example, amongst others, focus very heavily on the summary narrative. They call it a different term, but essentially the doctor is expected to write a report annually as to why they have met the curriculum outcomes. So starting it in foundation is to train them for the future. And we knew that the first year of it would be a challenge for foundation doctors, so we are there to train them to learn for their future selves. If the clinical supervisor finds the FY not up to date in her SLEs, should they inform the foundation doctor? Organiser, yes. Simple answer to that, yes. They should get in touch with the education supervisor and the FTPD. The rationale for the F2 LIFT training programme, I think probably we might just answer that separately, not as part of this question. It's basically to increase the experience of F2s into other specialties such as general practice, pathology, psychiatry, mental health, amongst others, to widen exposure and to increase satisfaction rates. That's a very brief summary, but there is a lot of work written about the F2 LIFT programmes. Will these changes affect F2 doctors this year? Yes, this is the curriculum going forward. Next question, which teaching topics outside the compulsory ones should the F2 concentrate on? Non-core learning is anything that is taught within the organisation. So that might be departmental teaching, it might be M&M teaching, it might be grand rounds. There is a very specific list on the UKFPO website of what is excluded. So study leave is excluded, courses and conferences are excluded, ALS, amongst others. So if you look at the UKFPO website, there will be a list of what is included and what should be excluded in the teaching that is outside the mandatory teaching. So, as I think I've answered quite a lot of this, was there evidence-based for increasing the demands of educators and foundation doctors in terms of writing and reading the summary narrative and do large number of PSGs? Does it improve patient safety, performance, or other benefits? Absolutely, yes. So I've answered the question about the summary narrative. We know that this is something that the trainees need to do for the future. Hence, we have included it in foundation. In terms of PSGs, we have data that supports that the PSG picks up performance and learning requirements that the tab does not, and that is why we have included it. It wasn't just purely on a whim, it was an evidence base that we have trainees with completed and satisfactory tabs, however, have competence and learning requirements that need to be addressed before they can move on to the next training year. So yes is the answer. Is a comment about trainees inviting PSG members. That may well be something that we do, but at the moment we have very much is a supervisor who selects their PSG because they know who is providing feedback. Another question about the summary narrative. We found that the more vague and narrative-based summary made it more time-consuming for the ES to complete the sign-off. And off the record, I heard that supervisors were actually less likely to read through the lengthy paragraphs and instead just tick the boxes. I find that disappointing. I think if anybody chooses to tick a box when they haven't read it, then that's very much their lookout. But remember, the trainees are often they can come back and complain if what they have written has been assessed fully. And I find that it's disappointing. Everything that we do, we should read before we sign off. The next question, SLEs, can nurses sign them off? Generally, nurses are not signing off SLEs. It tends to be doctors that are signing them off. Next
but I suppose if you had a specialist nurse who was doing a procedure with, they could sign a DOPS off, couldn't they?
They could, absolutely. And the senior nurses can absolutely and should be contributing to the PSG because they can make a very valid assessment and give valid clinical feedback to the foundation doctor on their performance. The next question is a trainer raised concerns in a PSG with a trainee. The remainder of the PSG responses were positive. What does the trainee clinical supervisor have to do in order to resolve this? Okay, so I think this is a very valid question, and we know that on a daily basis everybody's performance, interactions, etc. varies with people. If there is one negative PSG comment, then I think very much it's up to the supervisor, the clinical supervisor and the educational supervisor to look at the rest of the feedback, and if they feel that it is resolved and it is not outstanding, then they can close it off. If they feel that actually further evidence is required, then it's up to the supervisor to ask for additional support here. It's the same if it's the other way around, where if lots of comments are negative and one is positive, then we would not just necessarily dismiss the positive, we would ask for further feedback. And again, that just emphasises how important it is to have multiple comments about the foundation doctor. Another question here about the summary narrative. The word limit was limiting. Tony has answered that. We can increase the amount, the word limit. We kept it deliberately small because we didn't want to have trainees writing 3 pages worth, particularly if supervisors are not happy to read it. So I think it was to keep it short and snappy, and even bullet points if necessary. Another question here about the PSG being much more valuable if it could be prospective, i.e. set up at the beginning. I think we all agree with that. It would be much more valuable if it's set up at the beginning of the placement, but we know that sometimes for supervisors it can be quite hard to keep track of where the trainees are moving. So that's why we've included it in the CS induction report meeting form, so that it can be identified. But we recognise that there are challenges. Next question is about if the summary narrative is to be developed over 3 placements, what's the best mechanism to evidence this given the limited space? So as the trainee is writing their summary narrative, it will stay in draft form. So at the end of, say, November, so when I'm writing my summary narrative for HLO 1, 2 and 3, it's a live document, it's a live form. When I write it in there, it will stay there as a document that is sitting in my portfolio under summary narratives, and it can be reviewed by the supervisor at this stage. And in fact, within the portfolio, when they are signing it off, the CS can actually look to see what has been written within the summary narrative and can say whether it is progressing or not. There are progress reports embedded within that. And again, it's just to say to the trainee, yes, it's coming along nicely, or you've not started it yet, or this is perfect, you know, you're very much on track. So it does sit within the summary narrative, and it is a live editable form as things progress.
I think we're done. Yes.
Thank you very much, everybody, for sending in those questions. I really very much appreciate what you've sent in, and I really hope we've answered the questions. I'm hearing very strongly that we need more support and guidance for the PSG, the summary narrative, and some guidance about numbers of SLEs. That's what's coming through to me from the questions that we have been asked. That's really helpful to us because obviously this is we've written this curriculum and the assessment strategy. We've had one cycle of this. I think given the fact that it has actually landed reasonably well and that trainees have been signed off and completed their ARCPs, I think it's very promising, but this gives us food for thought as to where we need to continue to provide evidence and support for it going forward. So thank you very much for that. I'll hand over to Tony now.
Thank you. Yeah, not much more to add. Thank you, Fiona, for going through those questions remarkably succinctly. Yeah, it's obviously the areas that the issues arise. I would just like to point out, or perhaps remind you, that we have sent out questionnaires that we'd be really grateful if people would fill in and feedback on their experiences with the curriculum. There's about 10 questions in each one. There's one for educational and clinical supervisors, and there's one for FTPDs, and there's another one going around for foundation doctors. So, you know, if you see it, hopefully it should only take you 5 minutes to fill in. It would be really great to hear back some guidance on your thoughts on any changes and ideas. There's sort of successes and failures. and then we can take that forward and keep the curriculum, I suppose, current and workable. But I'd like to thank you all very much for your participation this afternoon. I hope we were able to answer your questions. If we weren't, there's the Foundation Curriculum email address, or you can send them into the main address and they can be forwarded to me there, and we can feed them back. And again, we will try and keep the documents up to date on the website. So thanks very much. Thanks to Kieran for moderating the questions and Claire for making sure the whole thing didn't fall over. So thank you very much indeed. And apologies for the short notice of this one, but we did want to get one in sooner rather than later, so we could get it sort of hot off the press post ARCP. So thank you all very much for your participation, and enjoy the rest of your afternoons.